morning, and thank you for joining us. I'm Dave Fullerton. I'm the Executive Director of the American Board of Thoracic Surgery. And this morning we have a conversation about training in structural heart disease. And I'd like our individual panelists to please introduce themselves.
Good morning, my name is James Edelman. I'm an Australian trained surgeon who recently has completed a structural heart fellowship with Dr. Vina Thorani at MedStar Washington Hospital Center.
Good morning, my name is Anita Kruger. I am a cardiothoracic surgeon trained in Dallas, and I just completed a year of structural heart training with Dr. Mack and his team at the Heart Hospital in Baylor, Plano.
Good morning, my name is Tom. I'm a cardiac surgeon in Houston, Texas. I'm about maybe 6-7 years out, and I finished my cardiac surgery training at Columbia. I spent an additional year at Emory to develop structural heart skills and transcatheter skills with Vina Thorani and Dr. Robert Drake.
My name is Yoshi Kaneko. I'm a cardiac surgeon at the Brigham Women's Hospital. I'm about 6 years out of practice, and I completed my residency at the Brigham Women's Hospital. Did an additional year of structural heart fellowship with Michael Davidson at the Brigham, and spent an additional 6 months with Chad Hughes at Duke doing aortic and wire work.
Well, thank you. Let me just get the conversation started by asking Tom a question. And Tom, I am curious as to how you came to focus your career in the area of structural heart disease.
Thank you, Dr. Fulton. I've always tried to live my life and my career trying to think ahead and think about where the future is going to be. And for me, as I started fellowship and was finishing fellowship, it was very, very clear that the future was in structural heart disease. And in fact, I would see a lot of press and media, and admittedly a lot of it from the cardiology side about the excitement, and I didn't see it just yet on the cardiothoracic surgery side. So I saw an opportunity. But I also appreciated that even though I had phenomenal cardiothoracic surgery training at Columbia, a very, very busy program, and also a program that where the original partner trial was, I realized that in my training, it wasn't enough to get transcatheter skills to really put me to the next level. So I knew that I wanted my future to be involved with structural heart disease, but also to be a valve specialist and be able to approach patients and treat the whole spectrum. So to be able to do open surgery, to be able to do minimally invasive surgery, and to be able to do transcatheter procedures with pure equipoise in parity with cardiologists.
Great. And you had a great mentor to follow there with Mike Davidson.
Yes.
And, was he influential in your decision?
Oh, absolutely. He was the reason why I decided to go to this field. And even during my residency, it was astonishing to see the collaboration, the concept of the heart team sort of infiltrating into the services. With the cardiologists and the cardiac surgeons working together, that was not really what I expected before I went in. And he sort of created that environment. And that was the main reason why I really wanted to do this for my future. And as Tom alluded, the training that we had during the cardiac surgery residency was more focused on open surgery. And we were also focused on obtaining the open skills because that was sort of the baseline skills that we needed to get. And the wire skills, especially the advanced wire skills, were something that was additional. And it was pretty clear to me that I was going to spend another year to try to obtain that skill after I completed my residency.
Speaking of finishing a residency, Anita, you recently finished.
I did.
And have completed your structural heart fellowship and are now launching your career.
Mm-hmm.
But as you think back about your time in residency, you obviously were attracted to this field.
Right.
But did you feel during your residency that you were getting what you needed to make a career out of it?
Yes and no. I think that it was very situation dependent almost. If I walked into a TAVR and there was another interventional cardiology fellow there who was interested, maybe they got to do a little bit more than I did. But if no one else was there and it was just me, then it really worked in my favor, and I would get to cross the valve and hold the deployment device and do some different things. So it was variable, I would say. And I didn't feel like anyone necessarily came to me and said, it's really important that you try to get in there and learn how to do this because it's going to be important. And so I kind of took some external cues and thought, you know, I really feel like I need to do a little bit more here. So that's what I chose to do.
James, is your experience similar?
It was very similar. I think that I didn't get the formal training in the wire skills during training. I did have some exposure. I was lucky to some transcatheter valve work. But I think spending dedicated time in the cath lab, especially learning from not only innovative surgeons but also interventional cardiologists, I was somewhat humbled. But I think I started the year thinking, oh, wire skills, that can't be too difficult. But they're far more difficult than certainly I'd anticipated. I don't know what the others' experience has been. And to actually start from scratch and learn from an interventional cardiologist these skills, I found particularly useful.
Well, the challenges that you've highlighted, I think, are what surgery as a specialty are recognizing. I think we kind of saw this at the front end, but I think it's probably fair to say that most people were really focused on open surgery, thinking that someday the catheter-based valve treatments would be predominant, but that day had not yet arrived, but it did last week. And so now, from the vantage point of the American Board of Thoracic Surgery, I think it's fair to say that we, as a board, look at, well, what might be the best way to train surgeons to be facile and to be legitimate structural heart professionals. Do you think that can happen during one's residency? Does the residency need to change? Is additional training necessary? Nina, let me start with you.
I think that it's possible to get some of the skills in residency, although I'm a little bit biased. I came from a 3-year program, and in that context I feel like, you know, if there was just a little bit more of the local culture that said, oh, you know, surgeons, we need to be involved, we need to get the wire skills and stuff, I think I would have had the time and would have been able to rearrange, you know, my priorities a little bit to get that done. I don't, like I said, I'm biased coming from 3-year. I don't know how a 2-year person would do it, but I feel like they might have a little bit more difficulty.
I think fundamentally we need a paradigm shift. I think historically surgeons have been defined by the scalpel and cardiopulmonary bypass, and even at centers we often brag, hey, we've done so many pump cases. But the reality in the treatment of disease is very disease specific, and I think the appropriate way is to become valve specialists or aortic specialists or lung specialists. And in that respect, I think does require a paradigm shift in treating disease processes, and that will require a paradigm shift in our training process. I do think it can be done within training, but I do think we need to have a set of core rotations or core requirements so that you can become facile at whatever you're interested in and have a cushion or a period that allows you to focus on what you're particularly interested in. I think that's one option. I think another option for those who can't obtain that is some training, postgraduate training, potentially one that's certified and accredited by various societies as well to establish credibility.
What about you?
You know, I think we had a meeting and Dr. Joe Viveria had said it clearly that there is no more T in TAVR. I think TAVR will be the standard in the treatment of aortic stenosis, and that we have to sort of appreciate. There has to be a change. I think our profession is at a point where we have to decide where we want to go. We have a 2-year program, and you know, out of the 24 months during the residency, the residents spent 6 months in thoracic surgery and 3 months in congenital. That leaves them only 18 months to do adult cardiac surgery. I don't know if we can train an adult cardiac surgeon that is sufficient in operative skills and also has a basic wire skills in 18 months. That will be a pretty difficult job. So, for the traditional fellowship, I think there has to be some sort of structural change to accommodate this shift in the paradigm. And it might be a little easier with the I6 programs because they just have a little more time. And also the thought of additional fellowship, I think, is a very attractive one, just like the ones that we all went through. I think that is probably the most, I would say the easiest way, but for us, probably the most closest way to get a sufficient wire skills for the surgeons that are graduating and going into practice.
I was hoping to add another additional wrinkle. I think it's more than just TAVR, and I think I think you need something that's more advanced and structured to establish those basic skill sets for transcatheter and wire skills, because we know the writing is on the wall for TAVR. It's been on the wall for a long time, and the writing is fairly clear on the wall for mitral disease as well, and tricuspid disease, and even arguably aortic disease with stent grafts for the ascending aorta and then TVARs. So I think that skill set, I think the impetus has been TAVR, but I think more importantly, it's more than just TAVR, fundamentally.
Now, James, you did a structural heart fellowship, and so obviously you embrace the idea of doing that. Do you think that other surgeons in training will be resistant to adding an additional year to their training experience?
I found it very valuable. Whether others find it, there will be resistance to it. I'm not sure. I think it's up to them. I do think extra training, specific training in structural heart disease is important if surgeons are to recognise that no longer are we going to be doing lots of straightforward AVRs. I think the definition of surgeons being part of the structural heart team, someone needs to change. I don't think just turning up to the cath lab or the hybrid OR where a TAVR is taking place, and I also recognise that we need to think more broadly than just TAVR, I think in the mitral, tricuspid and aortic space. We need something else to offer. The catastrophic complication rates that surgeons have the unique skills to fix are so low that we can't define our presence there and our justification for being there purely on being able to bail out a TAVR. I think we need to offer something, and I think surgeons can. We have great understanding, and I think the best understanding of the anatomy, the way that these valves work, the physiology of the heart. If we have an understanding and can drive the imaging software ourselves and be able to offer some unique insight into that from a procedural aspect, if we can, I don't think we need to be interventional cardiologists, but if we can have some competence in that, I think that is essentially important to be a member of the structural heart team, and then to decide on difficult cases. I think we need some formal training in that. You can't just turn up at the end hoping to expect to be involved if we can't bring something to the table. So I think that's where formal training comes in.
I want to emphasize what James said a little bit. When we talk about transcatheter skills, we often talk about the techniques in obtaining the skills, but I think there's more to it. And one of the things that James just mentioned that is crucial is the imaging part of it. And I don't think it's just for the structural heart, it's for every aspect of cardiac surgery. Looking at the TEEs, assessing the CAT scans for transcatheter procedures. I think these are crucial knowledge that we need to obtain. And currently there's no requirement for it. I think the disease management of these sick structural patients, I think that's another aspect that is underestimated. And that is something that we need to incorporate in the training for the future trainees.
No, I couldn't agree more. I'm interested in your thoughts on the following as well. I think one of the things I've personally learned by being involved with transcatheter therapies is the innovation that comes from it. So for example, the transatrial approach to mitral valve replacement in severe MAC using a transcatheter valve. That prior to surgical participation in transcatheter structural heart disease, we didn't know what to do with those patients half the time. And as pointed out yesterday, the mortality rate in operating on those people is quite high. So does that resonate with the rest of you as well?
I think you hit the nail on the head a little bit in that when you're dealt complex problems, I think the more people you have at the table with different skill sets allows you to come up with creative solutions for it. Again, the example was a patient with severe extreme mitral angular calcification that was not a candidate for a transeptal TAVR inside the MAC, was not a candidate for a transapical, and because we work with surgeons and some surgeons have minimally invasive experience and transatrial experience with access via the transatrial approach, we're able to come up with a potential solution. And I think that's where the field is going and where it should continue to go.
I can give another example. We recently had a patient that had significant PVL, perivascular leak, after mitral valve replacement. And the consultation went directly to the interventional cardiologist, and he attempted a transeptal PVL closure, but the location was more towards A3, and they had difficulty navigating the catheter into that location. And I happened to be in the cath lab for another reason, and they called me into the room. And after discussing, we decided to do a transapical access. We used the echo navigator, which is sort of synchronizing the echo findings and the fluoroscopy. And I opened up the apex, and we accessed through the apex. We navigated, and we actually got it closed. I think that's sort of adding another brain, just like Tom said, through a different training background to tackle one problem. I think it sometimes benefits the patient, and there's definitely a value in that, I believe.
So Anita, you started your career recently.
Yes.
And so you stepped into a new environment, new people to work with, trying to generate relationships within the hospital and the surrounding area.
Yes.
Do you think as you reflect on your transition into practice, do you think you would have the same acceptance that you're finding if you did not arrive with a credential of having completed a structural heart fellowship?
Honestly, I don't. I think that having done this year is really going to be, as you said, it's a very new thing for me. I've been in practice for about 3 weeks. But I think that having the credibility of having, not so much at the cath lab table manipulating the wire, but being in the discussions, looking at the imaging, participating in the planning of very complex procedures for complex patients, I think that's what gives me the credibility. And I think that the thinking among the interventional cardiology colleagues that I have would be, and rightfully so, that maybe I didn't do that in my regular training. Not to say that I couldn't have, especially if we, change things going forward. But I think that having done that additional time, and they know that I come from a place where it's a very high volume structural heart center where there is a lot of collaboration between the surgical side and the interventional cardiology side, I think that that's going to help. Certainly, at least I hope so. But I feel much more comfortable when I attend these conferences and I'm looking and I'm like, oh, okay, here's the coronary height, this is the sinus size, and for the mitral cases as well, here's the valve area. Look, I'm looking at the pattern of calcification here. I wouldn't have previously known to necessarily do those things and look at it from that angle, and so I'm glad that I can, and I feel that I add a lot more to the discussion, and it's not for me. I really feel that it's helpful for the patient.
Great. Well, as I mentioned earlier, I'm the executive director of the American Board of Thoracic Surgery, and the mission of the board is to serve the public. And as we take that mission very seriously. And as we look at the landscape of structural heart disease now, we recognize that the day has now arrived when we need, as a profession, to demonstrate our professional responsibility that surgeons who want to participate in the treatment of structural heart disease and care for these patients are well qualified to do so. And our current thinking, which I'm interested in your thoughts on our current thinking, is that the approach to that should be an increasing exposure to the treatment of structural heart disease during one's residency. And then for those that really want to devote themselves to it, such as you all, generation of accredited fellowships, formal fellowship training in structural heart disease in addition to one's residency. How does that resonate with you all?
I think it's imperative. We know that currently a third of the cases that we do as cardiac surgeons are related to structural heart disease. We also know that the field is moving very rapidly towards transcatheter minimally invasive approaches. So I think if we're not proactive about developing the skill set to be in that space, then the reality is, as surgeons, we will doing less cases of all structural heart disease. I think it's important to have some formalized, structured training process. I think structural heart disease, that said, as Dr. Elman alluded to, it is complex enough in itself, and you need a way to have a structured way so that people learn, but also afterwards, when we arrive at different centers and try to assist programs, that there's credibility in what we've done. So I think it's very important to have a pathway for those in training, but also for those who want to dive deeper, a more formalized structured pathway, with some kind of certificate post-training.
Do you share that view?
Yeah, I share exactly the same vision as Tom. Right now, the board requirement for TAVR is 5 as a primary, even for cardiac track. And I think there are additional categories, including balloon pumps and other wire skills. But clearly, that is not going to be enough to navigate through this paradigm shift that we're experiencing. So there has to be a change to have a baseline skill for the graduating traditional cardiac surgery residents. On the other hand, does all cardiac surgery residents need to have a transeptal skill? That I do not know. That may be more of an advanced skill. And for those who want to pursue their career in structural heart fellowship or structural heart disease, maybe that is a pathway to go through a fellowship to obtain additional skills. I completely agree with you.
Since you two did structural heart fellowships, I assume you would share this with me.
Absolutely.
Is there anything else that we should cover?
One point that I think we've got to recognise that having surgeons at the table with structural heart disease is going to be good for patients. I think just like there are some patients that are best served, there's a lot, we've just seen the randomised trials, there's a good proportion of patients that are well served by TAVR compared to SAVR, for instance. We'll extend that into other disease processes. I think there are going to be patients that may end up getting TAVR that really should have had a surgical valve. As surgeons, we can offer the equipoise that Tom mentioned earlier. I think we need to remain at the table and to be able to offer patients the right treatment for their disease.
I'd like to add that during my structural heart fellowship, I had the opportunity to be very immersive in the cardiology, culture, and environment. And I think the training paradigms that we develop, I think that's important as well, because I learned so much from not only the cardiology attendings that were teaching me, but in the trenches, cardiology fellows. And I think it was very unique to have, at that time, a multi-specialty training process where we're both getting access together, both trying to cross the valve together, both trying to figure out what's the best treatment option for this patient together. That I think hasn't really had a precedent so far. But the environment that we're at Emory was very unique, and we were really training hand in hand with the cardiologists. And there's almost we're almost undifferentiated, right? We're in the cath lab about to do a transcatheter procedure. It wasn't, okay, Tom, you're the surgeon, and so you're the cardiologist. It's like, hey, you're the physician. Let's go ahead and try to get access and take care of this procedure. I thought that was very special.
I'd like to add that we are not trying to create, one of the criticisms that this fellowship may get is that we're trying to create a cardiologist. We're trying to create a surgeon into an interventional cardiologist. But I don't think that is true. I think what we're trying to do is to create a valve specialist that has different training background, that has the benefit, the patient will get the maximum benefit from having a valve specialist from different backgrounds, so that they can tackle the patient's problem and solve it. And I think that serves the board's purpose very well.
Well, thank you all very much for joining us this morning, and thank you at home.